Boston's Brigham and Women's Hospital has been a destination for advanced healthcare for nearly 2 centuries. Consistently ranked one of the country's top hospitals by U.S. News and World Report, men and women come here from across the U.S. and from over 120 countries worldwide. A long-standing teaching affiliate of Harvard Medical School, the Brigham is home to profound, life-giving breakthroughs, like the world's first organ transplant, and continues this today with new ways to prevent disease and to maintain health. The Brigham is a biomedical powerhouse. Its discoveries affect all of us, such as the impact of a daily aspirin in preventing heart attack and deciphering the role of amyloid protein in Alzheimer's disease. And the Brigham is dedicated to training the next generation of healthcare providers. Many of our clinicians and alumni are leaders in medicine today, transforming the future of healthcare to improve lives everywhere. Learn more at brighamandwomens.org.
Mark, I'll turn it over to you.
Terrific. Well, I enjoyed the last panel and look forward to continuing this conversation on behalf of Dana-Farber Brigham and Women's Cancer Institute. I think we have a very interesting panel today. I want to leave a fair amount of time for conversation. Basically, as we talk about COVID, there are a few phases that we think about. One was pre-planning before we knew there would be a COVID. How do we react? How do we improve? And what changes are going to be sustainable? And I hope that we'll address all of those with our really expert group today. We'll start with Dr. Goralnick, getting to planning and how we were thinking about all these possibilities even before they occurred. Dr. Eric Goralnick is the Medical Director for Emergency Preparedness and Access Center at Brigham Health. He's responsible for system-wide efforts to prepare, mitigate, respond, and recover from disasters, in addition to coordinating all outside hospital transfers in the system. He's also a veteran, a Harvard Medical School Civilian Military Collaborative member, and has led many different efforts in this regard, really a world leader in preparedness and emergency and disaster response. Also a graduate of the United States Naval Academy, Sackler School of Medicine in Tel Aviv, Yale, New Haven Hospital Emergency Medicine Residency, and a good friend and faculty member at the Brigham and Dana-Farber Brigham. Dr. Goralnick.
Thanks so much, Mark. I'm going to go ahead and share my screen. And Mark, give me the thumbs up if you can see that.
We got it.
Great, thanks so much. So thank you so much for allowing me a few minutes to speak about our recent experience and our preparation. You know, obviously COVID has changed the way that we look at the world in so many different ways. And I wanted to really focus us on emergency preparedness efforts and explain the concept in the field of emergency management, because obviously this pandemic has brought new light to this field, in addition to several of the principles that we have applied during prior events. For example, the Boston Marathon bombings in 2013, multiple snow blizzards, 2 active shooters within our healthcare system within the last 5 years, in addition to multiple information systems downtimes and day-to-day activities. For example, last week when all of our HVAC systems went out and covering our operating rooms, how do we prepare for that? How do we respond? How do we navigate? And how do we ensure safety throughout? So the field of emergency management is really based on 4 cycles. Those cycles include preparation, mitigation, response, and recovery. These cycles each require a certain level of discipline to apply some principles to either reduce risk, to ensure readiness, and during the actual event to train and drill so that you have the teams in place that can default to their level of training. I mean, ultimately, individuals and teams default to their day-to-day and rarely will be able to respond in a novel way in the acute setting of a crisis. And the final piece is recovery. And we're in this space right now during this pandemic where we're doing a little bit of all four of these at any given time, because it's not clear if we're in a surge, if we're heading into surge, we're coming out of a surge in many cases. So it takes a little bit of gymnastics to navigate each of these. And recovery typically is something that's often ignored, but quite frankly is one of the more important aspects here. And recovery is critically important because we're talking about maintenance of continuity of operations. In our example of COVID, and healthcare is not just to care for COVID patients, but to ensure adequate care, open and safe care for non-COVID patients during this time frame, and trying to prevent delays in care that would cause complications, which we've seen from many past disasters, particularly Hurricane Katrina and Sandy. There's a fair amount of data on issues around patients requiring dialysis and not having access, in addition to diabetics and not adequate access to medications and other resources, which then have caused significant complications over time. So recovery is critically important. And when we did a meeting about 2 years ago, we gathered individuals that represented multiple European nations, US, some Middle Eastern countries, and they were clinical leaders that had responded and prepared for a variety of different terror events, whether was in Brussels, Paris, et cetera. And what we learned from them really was recovery was the biggest gap. And we really need to focus and initiate more robust efforts on identifying recovery from the beginning. When the event starts, recovery begins. Another key piece to refine. So we'll discuss 5 principles. 1, defining your mission from the outset. So if we go back here, you can see this is dated in January of 2020. Feels like a long time ago. Karl and Mark are looking at me a little sideways right now from our experience. This was the total number of cases in the United States. Now we have the total number of deaths over 200,000, about 1,000 deaths a day in the United States currently, in addition to over 1 million cases. So it's really quite concerning how the United States, traditionally known as one of the world's leaders in healthcare, is really in the midst of a humanitarian emergency, unlike anything we've seen before. And this obviously is a global issue, but each of our countries has been hit in a variety of different ways. So this was the beginning. This is January, and from the outset, we wanted to ensure that our mission was to not only be open and accessible for care for COVID patients, but open and accessible for all other essential medical services during this event. Well, what happened shortly after that was there was an event where Biogen, which is a pharmaceutical company many of you are aware of, they held an international conference. It was in Cambridge, which is probably about 10 or so miles away from where Brigham is located, 5 to 10 miles. And at this hotel and complex, they had several hundred individuals. There were two known cases of COVID from that, and then it started to spread like wildfire. So Boston, along with New York and Seattle, were some of the first places hit in the country. And ironically, we after we had a large retreat where we defined that mission, we gathered teams, we were getting ready, defined our incident command response team, which I'll go through in a minute. Within 48 hours, we got a call from the Department of Public Health in Massachusetts that said there was an event. There are several hundred individuals that need to be tested and we need your help. And that was a call between us at Brigham, Mass General, our colleague Mike Klumpus, myself, 2 colleagues from Mass General, which is our sister hospital across the way. And we needed to basically rapidly set up a testing center in short order. So we gathered in our emergency operations center, and look how people are. This is the beginning, right? There's no social distancing, no masks. It feels like another time. And we didn't really know what we were doing, quite frankly. And we were all learning from this. I had, for a decade run around the hospital and said, we've got to be prepared for a pandemic. We've got to do X, Y, Z. And people thought I was crazy. And they said, okay, go about your way, Dr. Goralnick. but it turns out I wasn't crazy enough, as many of us. Dr. Davis has pioneered some of this work many years ago. And we gathered in a room, we began to work out through the issues we would need to respond to this particular event, which would include rapid testing. And within about 12 hours, we set up a drive-through. This is our emergency medicine nursing director, our clinical director aligned here, where we set up a drive-through where vehicles could drive through. This was one of the first operational drive-throughs in the country. We had seen this, actually. We saw this set up in England. And we actually saw this in South Korea, where they're doing drive-through testing. So we set this up within a pretty short order and learned from whatever data we could get from those other sites to operationalize this. So we set up this drive-through in pretty short order and kept focused on the mission, which was to maintain caring for our current patients and open up for COVID. Number two is organizing your team. So you saw a shot of us in our emergency operations center. And what we immediately implemented was our hospital incident command system. And the incident command system is a construct that is now global. One perspective on incident command really began in the United States, and that began during some wildfires in California. Those wildfires spread across state lines, and there were multiple firefighting agencies that responded. But what was clear was really nothing, in the sense that it was a complex, dynamic event, and there were multiple agencies that responded. They used different forms of communication, different radio frequencies, different codes, different structure in their response, and there was minimal integration across different fire services. So in the end, what happened is there was a lot of complexity, a lack of really an adequate response in a timely fashion. And this led to a major review that was led by RAND, in addition to FireScope, which was essentially a group that was commissioned by the state agencies in California to look at this response. And they came up with this concept of the incident command system. And the incident command system is essentially an organizational structure that takes a matrixed organization and streamlines that organization. So it provides role clarity, responsibility, accountability, and authority for each of those various individuals that are identified and the teams that are identified to support the mission. And it's really structured in this concept of having an incident commander who is essentially the most qualified individual that is on scene for that event. So that would start off, typically an example in our hospital would be our nursing administrator is the most senior qualified individual that has a sense of what's going on at 2 a.m. at Brigham Women's Hospital. If in fact there is an event that occurs at 2 a.m. and we need to call in reinforcements, it may be a senior VP that assumes that role, but they've got to come in physically and assume that. Until then, it's the first person on scene that's most qualified. And that was, began with the fire services and has continued across all public safety professionals. So there's the incident commander, there's the command staff, which consists of your safety officer, any information systems, subject matter expertise. In this event for COVID, we have an infection control officer, a hospital epidemiologist, along with emergency preparedness, and liaisons who are our linkages with other private or public sector entities, in our case, government and other healthcare systems. And then you have 4 buckets, 4 sections: operations, planning, logistics, and finance. Planning are the individuals that are the thinkers. They're the ones that say, our operational period is 24 hours. Let's think about tomorrow and the next day and the next day, and they set objectives to achieve during those timeframes. Operations are the doers. Those are the ones that focus on that current operational period and they execute. So planning says we need to build capacity for 30 more patients within 24 hours. Operations sorts through that and builds the capacity to do that and shifts things around to make that happen. Logistics is all the support resources we would need, you can imagine, and finance. You need easy and ready access to funding to implement many of these innovations during an event. And what's key is it's expandable and contractile. You can mix and match with other organizations because we're all speaking the same language and can embed with each other. So that was in the early 1970s. In 1982, there was an aircraft crash in the Potomac River. The Potomac borders Washington, D.C., Virginia, Maryland, and during that event, what happened is this aircraft crashed. Over 95% of the individuals that were in that aircraft died. and you had response from several different public safety professional agencies. And again, there was a lot of confusion, having challenges working together, different codes, different radio frequencies, different ways that they would establish a scene protocol and command. So what they did is they commissioned another group afterwards. They looked at what had been done on the West Coast, and they adopted ICS on the East Coast. And really not until 2004 did this become a national standard for public safety professionals. In the late 1980s, with Orange County in California was commissioned as the first group to put together the concept of hospital incident command. And as you can see, it essentially follows the same structure with some of the key roles and functions that would be unique to a hospital organization, but still has the same sections: operations, planning, logistics, finance, incident commander, and that key command and general staff. And there's recently been a revision of the HICS organization. When have we used HICS? Well, we've used it. I've been here for a decade. We've used it for every major and minor response that we've had. The examples I gave were earlier: Boston Marathon bombing, Ebola response, Snowmageddon, which was in 2015, 2 active shooters in January 2015 and just a few months ago here. And in addition, we've used it for planned disasters. People laugh a little bit, but when we went live with Epic in April of 2015, that was a major change. That was a major lift for our organization. And what do? We used our hospital incident command system to streamline how we organized, how we responded, how we planned. And we did that across the organizations. In that case, we actually used a European model, which is based on gold and silver and bronze categories of leadership, because we had this really across the enterprise and implementation. So different forms of incident command exist, and you've got to be malleable to adapt that to your scenario. Here's the example chart from our HICS response, and this was back in February, and this has mixed and matched over time. Principle number 3 is get data. And I'll quote Nancy Pelosi, who said, multiple anecdotes do not equal data. And this is what we're seeing, is that early on, there was a predictable surprise. The predictable surprise is that COVID and this pandemic will disproportionately impact people of color, Black, Brown, Latinx, Native Americans, and other health disparity populations for a variety of reasons. It's a predictable surprise because we know this on a day-to-day basis. There's disparities in healthcare for our various populations on day-to-day, and disasters just exacerbate the day-to-day. And we've seen this with other large-scale disasters. A lot of great data out of Katrina, Hurricane Sandy, but Hurricane Katrina was one in particular where we've seen these significant changes. And in Boston, we saw this really pretty early on with Black and Latino populations, Latinx populations, a significant burden on those populations, both in deaths and disease. Now, once you acquire the data, we've got to act on that data. So what do? We had wonderful leadership within our organization, within the city, to transparently show that data. It took time to get these boards up. We've got a wonderful team led by a gentleman by the name of Rob Forsberg, who has a wonderful way of displaying data with the various tools that we have. And with regard to our health disparity populations, we had a group that was commissioned led by Cheryl Clark, Wanda McLean, Sunny Eapen, all leaders within our organization, to really focus on ethnicity, race, language, and all of the various perspectives and different issues that may arise that are unique to those populations, not only to identify, but mitigate those issues. And they really had started a robust effort with various domains to embed equity roles within our hospital incident command system and tackle this. And every Thursday at 5 o'clock, there's a meeting. There's about 550 people on that invite that all team on various responses. And it's been a wonderful experience to see this, but really it's just the beginning. The question is, what's durable and can continue after this pandemic? What do we need to do right now? And how do we sustain this important effort to mitigate these disparities in both care and outcomes? And here's some of the results of their work. They really led some robust community testing out in the community, recognizing food insecurity is a significant issue, providing food for individuals, registering voters. As you know, we recently had a large election here in the United States. and all of these various issues that were addressed. And finally, perfection is the enemy of good. Colin Powell, our former Secretary of State and former commander of Joint Chiefs of Staff, he used to say, use the formula P equals 40 to 70. P stands for probability of success, and the numbers indicate the percentage of information acquired. The bottom line is, as we like to say, bottom line up front, BLUP, which is don't wait till you have 70% of the information to make a decision, and don't make a decision before you have 40% of the information. This is where we are. We're in the midst of a pandemic, and what's done is done, and we've got to learn from these experiences and move forward. But we're never going to be at 100% of the information. We're probably rarely going to be at 80%. So do the best you can and really focus on those core values of integrity, honor, courage, and commitment. Finally, I just want to summarize, we're in a tough spot. We're in a tough spot now. This is where we are now. You remember those numbers were in the hundreds in January. This is what it looks like globally. This is from the Johns Hopkins website. But the opportunity here is around education, of embracing science, of those basic principles of social distancing, masking, and hand hygiene. And if we can build trust within our communities, within the public, and keep focused, we can mitigate the impacts and flatten the curve. Thanks so much for your time. I'll turn it back over to Dr. Davis.
Eric, thank you so much for an amazing presentation and really for your leadership at the institution nationally and internationally. It's really impressive and greatly appreciated. We now move, as I mentioned, that as most of you know, we do our cancer care together, Dana-Farber and Brigham and Women's Hospital, and it's a pleasure for me to introduce Dr. Hibah Osman, who is the palliative care physician at Dana-Farber Cancer Institute and Brigham and Women's Hospital and assistant professor at Harvard Medical School. Dr. Osman recently joined our International Patient Center as the Associate Medical Director of Oncology. Before Dr. Osman moved to Boston, her work focused on the development of palliative care in her home country of Lebanon and across the Middle East. She is founder of Baslam, the Lebanese Center for Palliative Care, and the founding director for the Palliative and Supportive Care Program at the American University of Beirut Medical Center, where she maintains a role as an adjunct faculty. Dr. Osman has already made incredible contributions to evolving the program at Dana-Farber and Brigham. Dr. Osman.
Thank you, Mark. It's a pleasure to be here. I'm going to take a minute to share my screen. I only have a few slides. Okay. So it's a pleasure to be here and share our experience with COVID at Dana-Farber and the Brigham. Like Eric said, Boston was hit early in the pandemic, and like all healthcare institutions, we were looking at ways to maintain the work that we do under very difficult and challenging circumstances. In our work or our efforts to continue our work, our leadership was guided by our mission and core principles, which you see here. Our work is not only focused on clinical care, but we also have a big focus on research at the Dana-Farber, as well as we also serve as an educational center for learners at Harvard Medical School. And we are very much rooted in excellence and also compassionate care and respect. I really liked what Dr. Abu Alfa said earlier about, he referenced a study about the care provided, or the social care provided to breast cancer patients, and how that improves outcome. And this is at the core of our work here, the multidisciplinarity, the continuity, the addressing the psychosocial dimension of care, especially in our cancer patients who are very vulnerable, not only physically vulnerable because of the nature of their disease, and the circumstances of COVID, also the depressed immunity from the disease as well as from the treatment makes them at higher risk of catching COVID, but also at higher risk of complications. So as we worked to change and continue our work, we had these core principles in mind. And I'll start with our focus on the safety piece. Many of these will be familiar to you. So very quickly after COVID hit, staff was sent to work remotely. Any staff that didn't necessarily have to be on site was working from home, and this happened within essentially overnight. PPE and ensuring availability of PPE for the staff who had to be on site was also a primary focus. We shifted a big chunk of our care to virtual care. So patients who didn't have to be on site were receiving care remotely. So if they weren't coming in for infusions or radiation therapy, although we didn't have essentially any significant virtual component to our care in the past, within a week or two, about 50% of our care was moved to telehealth. COVID screening was implemented for staff and for patients. So you see here my COVID pass every morning. We still have to do this every morning. We go in and go through a symptom checklist and have to show our COVID pass every time we enter and exit the hospital as staff. And for patients as well, screening is done at multiple levels. So anybody who's coming in to our hospitals is screened. And then we instituted a visitor policy, which restricted the access of visitors to the center. This was, of course, very challenging, especially with our cancer patients with high psychosocial needs. So patients who were admitted did not have access to visitors, but also patients who were coming in for outpatient visitors had to come in on their own. And this was necessary to reduce the volume of people on site. And because of these interventions that we had to do for safety reasons, the relationship aspect of our work was very compromised. And so there was a lot of effort to try to maintain that because we know that our cancer patients are very vulnerable and they live in a time of very high anxiety and uncertainty. There were many innovations, many rooted in our nursing colleagues who were at the bedside and used iPads and FaceTime and Zoom and different innovations to try and keep families at the bedside, keep them informed, help patients communicate with their families who were outside, but also for the team to communicate with each other, which was essential for our role functioning. What I'm highlighting here, and this is actually the only reason I decided to do a slide presentation, is because of a couple of projects that I thought were very innovative and give a nice idea of the kind of work that we do here. So many of you are familiar with interpreters that are available to patients who are from other countries or from the US, but are not English speaking. They have access to interpreters who help interpret the conversation between the provider and the patient. Our interpreter program, we actually have what we interpreter ambassadors, and this is only a small part of a much larger group. And the goal of this program is to have the interpreter actually play a core function in the medical team. So the interpreter is not just translating or interpreting, but also serves as an important resource for patients to help the patient to bridge cultural barriers, to help guide the patient through their process here. Here were several buildings connected by bridges, and so it can be hard to navigate. And when a patient is there on their own, it can be hard to navigate. So they connect them to resources, direct them. And this program was available before COVID, but as you can imagine, became much more essential during COVID. So that when the patient is here and receiving care, they are connected to one interpreter that they see across multiple visits, and there's some continuity in that relationship. And we found that that has been essential and very important. Another project that you see here on the right is the Get to Know Me project. There was a lot of distress, especially with the very sick patients in the ICU, but also in patients in regular rooms, with PPE as a big barrier between the patient and the provider and the family not around. Some of our providers conceptualized this project that involved gathering information from family members about patients who were admitted to our hospital and using this information to create posters. So this is a mock-up, so it's HIPAA compliant, it's not a real patient, but we would have Harvard medical students interview family members, obtain this information, and this was giving a clear message to family members that we saw the patient as a person, and we wanted to connect and engage and treat their family member as a patient. So it was a way for them to advocate for the patient who was on the inside. And they would interview them and develop these posters that were put on the doors or the glass of the ICU room so that staff taking care of that patient knew them as an individual, and that helped bridge that relationship and maintain that warm connection. Just a few words as well about the International Patient Center, as that's a big part of my role and what Mark was talking about earlier. Obviously, with travel restrictions and COVID, the volume of patients coming to receive care here in Boston was significantly reduced. We're seeing the numbers gradually increasing now. But with COVID, there were patients who were receiving care here who were stuck in Boston, and this was a big challenge. So are supporting them and protecting them and working to help repatriate them when it was safe to do so, with travel arrangements and COVID testing, but also while they were here, helping keep them safe. So we had concierge services with delivery of medications, sometimes assistance with grocery shopping, and transportation, safe transportation as needed were instituted. And then there was a big restriction of patients who were in their home countries who couldn't come to Boston. So these were new patients who wanted to receive care here, but also established patients who wanted to continue their care here. And as you can imagine, there was a lot of distress when they were not able to return to continue care here. So we depended in this situation a lot on virtual care. And it's been mentioned several times before in the sessions this morning, the challenges of virtual care across borders with licensing, with data privacy laws and sharing medical data across borders. There were major restrictions, but we were able to provide virtual visits for our established patients and have been very creative with the online written second opinion platforms and continuing to support patients while they wait to come to Boston. And then this was also referred, the third piece was referred to earlier in the presentation, is the importance of collaborations in the work that we do. And I have to say, one of the silver linings of COVID has been encouraging these collaborations. So because of these restrictions across borders, I feel that our work, our communication with our colleagues in other countries have increased dramatically with regard to patient care, to providing continuity, to providing support to patients who couldn't make it to Boston, who would have otherwise been here. And that's pushed those efforts in that direction. Thank you.
Thank you, Dr. Osman, for a terrific talk and all of your insights. And then finally, I'd like to invite Dr. Karl Laskowski to give us our next presentation. Karl and I have worked together in a number of different areas, starting in population health and other global activities. And currently, Karl is the Associate Chief Medical Officer at Brigham Women's Hospital, Brigham Health. And in that capacity, he is part of the senior clinical leadership of our ambulatory enterprise. He coordinates efforts to improve access, efficiency, quality, and value. He's had several leadership roles at Brigham, including, as I mentioned, on population health, process improvement, and innovation. Dr. Laskowski maintains an active general internal medicine practice as a graduate of Yale and of Harvard Business School. A good friend and colleague, Dr. Laskowski.
Thanks, Mark, and thank you everyone for having me here this morning. Let's see if I can share my screen here. There we go. Right. Slides good, Mark, Eric? All right. So thank you again for having me this morning. I'll spend the next 10 or 15 minutes just giving you a little bit of information about how we at the Brigham thought through the pandemic crisis as it started in the ambulatory sphere, the lessons we learned from that that are applicable both to how we may handle the ongoing crisis and subsequent surges that may happen, as well as things that have fundamentally transformed our ambulatory operations and how we might better serve patients in the future, and really pushed innovation in a way that I don't think many of us expected at the outset of the pandemic. Many similar learnings to what Dr. Osman had mentioned with cancer patients that are applicable sort of across the broad sphere of specialty and primary care for the patients that we give to many, many patients across the course of the day here at the Brigham. When we started this journey back in April, Eric showed a couple pictures of how we were excited and sort of intellectually engaged with what we thought was a neat exercise. The other thing that I would point out is that it seemed very inpatient focused and really ICU focused at the outset of the pandemic, and that has evolved over time. If you look at the course of the pandemic in Massachusetts and the diagnosed cases, really seeing a spike beginning with the Biogen group back in March, and then across the state and very, very busy in terms of diagnosis and patients getting sick into May and into June, where after the lockdown measures that the state put in place, and all of us being much more conscious about how we were carrying ourselves and what we were doing in our daily lives, no longer sitting next to each other eating food in conference rooms like the picture Eric showed, put us in a better place. What you see in parallel to that kind of diagnostic curve, how many people were tested positive, is the admissions to the hospital. And they line up almost exactly. It's really striking how a diagnosis back in March was directly proportional to the number of admissions. This has actually kind of fallen off as we've gotten later in the surge, and a diagnosis today for a number of potential reasons doesn't necessarily lead to a proportional admission. And this isn't to argue that every patient who was diagnosed was admitted to the hospital. That's certainly not true. There were many patients diagnosed who were not admitted to the hospital, but there was a direct correlation amongst the two that was striking, where you got another diagnosis, you did get some percentage of those people admitted to the hospital. And more lately, we've seen more patients get diagnosed and not necessarily need hospital care in different proportions. But the focus, because of this correlation back in April and May, was really on inpatient capacity. How do we build out additional ICU beds? How do we make sure we are staffed as an institution to take care of the acute needs of these patients? And how do we not collapse the hospital system under what was really a crushing load of very, very sick individuals? That is presented some interesting problems for outpatient care and things that people very quickly realized. How are we going to take care of all the patients who didn't have COVID, who weren't sort of acutely ill, but who had ongoing medical needs that could not wait? And what we saw in the beginning of this was understandably volume of outpatient visits that went from something around 200,000 per month down to 50 or 60. So 75% of our volume disappeared. Patients did not come in to see us. And some of that was by design, in that we shut down clinics, either because we didn't think they were safe or we needed to redeploy staff to inpatient settings where they were more acutely needed. And some was because patients didn't feel safe coming to see us, even if they did need the care. And we were able to offer it to them because we were committed to providing that necessary care to everyone, regardless of whether they were in the emergency room or at their home. What you will also notice is that virtual care went from almost nothing, about 300 visits per month, to almost 60,000 in 2 months. And this is very similar to what Dr. Osman was saying in relationship to the Farber. We had been experimenting in virtual care, but had not really used this as a way to take care of our patients. But when push came to shove and we could not see them personally, face to face, we were able to do this in a very, very high volume way and turn things on very quickly, so that we were seeing a large volume of patients via video or even telephone visits to try to provide them the care they needed throughout the pandemic. And that has continued. If you look through the rest of the summer, while our in-person volume has returned, and I'll show you some additional data later that shows it has continued to even increase a little bit, the virtual care has not dropped off. We didn't turn that off. When we've gone back to seeing a lot of patients in person, we still see a lot of patients virtually. And we tried to figure out what is the best patient population that can be seen safely this way, and where it is more convenient for both the providers and the patients. And how do we integrate this into our operations in a way that seems coordinated and not as a response to a crisis? So that is the work, I think, still to come. When I reflected on kind of what are the learnings from COVID and kind of what did we take away from this, there were 5 themes that came out. The first 2 were really around how do we maintain safe operations in the ambulatory setting during a crisis. And in this particular crisis, both things that Dr. Osman already referenced, screening of patients prior to visits. We want our staff and our patients to feel safe. So we need to identify people who may be ill ahead of time. And then decide how to best deal with them. If they need to come in, how do we get them in safely and prepare and not be surprised when they show up in the door with a fever or a cough, but know that ahead of time so that we can best care for them. And if they don't need to come in, how do we switch them to virtual or do something else that would help keep everyone socially distanced and still get the care that folks need? Dr. Osman showed you a little bit of this already. The apps that many of our folks at the institution have developed around texting or sending via email to patients and staff ahead of their visits, where you enter a bunch of questions around: have you been diagnosed? Have you had close contact? Do you have symptoms that would be potentially consistent? And if you answer yes, it prompts you, if you're a patient, to contact the clinic and discuss this ahead of time. And if you're a staff member, it tells you don't come to work. And as of this week, actually helps you get tested. You can schedule testing directly from the app in some locations as we move forward. The testing strategy is the second piece of this maintaining safe operations. For those patients who do have symptoms, or for staff who have symptoms, we need to be able to get them quickly tested, identify people who are in fact positive for COVID, and treat them appropriately. We monitor this very closely with a lot of analytics around what is our capacity, and supplies and staffing have been a challenge throughout this. So we wanted to manage this very closely and understand how much testing do we have in various locations, how much are we seeing, and what are the indications, and how much is positive, so that we can adjust staffing and testing platforms as best we can to meet the needs of our patient population and staff, and really come up with practical guidelines that require testing in the right circumstances. So certainly exposed or symptomatic folks should be tested. We test our pre-procedural patients before they come in if they're getting an aerosol generating procedure, and have changed these rules throughout the pandemic as we've gained more information about what is going on in the community and what is the risk given the prevalence of COVID and the PPE requirements. The next themes really have to do with adapting for the future. As we're thinking about coming out of a crisis situation and going into something that is a little more of a smoldering fire, what do we learn and what do we take away from that? But the first question was whether to maintain a really centralized approach, and I'll use the respiratory care as an example of this. During the initial phase of the pandemic, we set up centralized respiratory illness clinics, where we took anyone who had a cough or shortness of breath or fever and really had them come to a single clinic, right? There were 3 of them, 3 clinics spread out throughout the area, instead of going to primary care or instead of going to urgent care. If you needed the emergency room, you could still go there, and we had all of the kind of infrastructure. But for our ambulatory patients, we tried to centralize this in locations where we could control it and make sure that people had the training and equipment they needed. As we've come out of the crisis, we decided that a distributed approach was much more optimal, in that it helped our patients access care closer to their homes. It made sure that our staff were prepared if an unexpected patient did slip through, despite all of our kind of screening work. And preserved our resources in ways that allowed us to care for patients across the network in all of the locations that we have. And that was a long discussion about how do we do that, and really what are the pros and cons. But taking this back out to the community and doing it in a more geographically spread approach was what we thought was best, and prepared us for future care. And then finally, the point about virtual care not going away. And I'll come back to these data that I showed in a slightly more truncated version earlier. Even extending out into September and October, what you'll see is, as a percentage of all visits, the light blue there, virtual care, has settled out at 20 to 25%. And we actually set institutional goals for our department chairs and senior leadership around maintaining some percentage of virtual care volume. Patients like this, and I think it's not going away. I like it as a clinician, as an internist. Like, it is nice. This afternoon, I'm going to do an entirely virtual session. I will do it right here from my administrative office, and I don't have to go anywhere. It does provide some challenges in that I have a medical student that I now have to integrate into a visit that is no longer in person, and that's required me to think a little bit creatively, but we're getting experience with this and really figuring out how do we integrate it into usual operations so it feels just like it would to come to the office, except that you're in your living room and don't have to drive in. And it has a lot of pros in that regard. Finally, we really spent a lot of time trying to figure out how do we plan for the unknown. Eric talked about the emergency response, emergency preparedness approach to this, which really takes us from a place where it feels reactive and a little bit behind the eight ball to something that feels more flexible and appropriate, almost usually proactive. And that is great. I think as we come out of the crisis and get out of the incident command structure, what we would like to do is get us to a place where it feels resilient. COVID has been very humbling. I tell my patients, and I've told my family, I've stopped trying to predict what the world is going to look like in 2 weeks, let alone in 6 months. And that presents a lot of problems when you're trying to plan how an organization will operate and how we best care for our patients. By kind of thinking through these sort of problems, and in our experience with the pandemic, we've gotten to a place where we are kind of proactive but flexible and able to follow a lot of those rules that Eric was talking about, with relatively limited information, being able to kind of pivot and better react to new data and approach things from a resilient manner that allows us to best care for our patients. And I think it's been while a very challenging experience, something that's made us much better as a system and much better as a group, and really a learning experience for us. Mark, I'll turn it back over to you.
Great. Thank you, Karl, for another great presentation. That was terrific. I'd like to pose a couple questions. Well, maybe we'll kind of do it rapid fire and see if we can get as many questions in as possible. One, I'll put you guys on the spot a little bit. What's the biggest surprise as you look back with all of the thoughts and planning, and what surprises you the most? And it doesn't have to necessarily be directly medical. Was there a social surprise? What in your experience are you most surprised about that may lead you to think differently about unexpected things in the future? Who would like to go first?
I could take it. The biggest thing for me is the pervasive lack of trust of science within the public. You know, that has been, you know, unfortunately promulgated by many of our leaders. A total, and what's built on that is a total absence, despite multiple efforts to have pandemic planning here in as part of our thought process, as part of our federal response, local response, total gap in our federal response and needs. And I think a lot of this is built on a total or a big gap in the public's trust in science and our leaders' mistrust in science. And, you know, it's something we've all got to navigate moving forward. There's no easy answers. But really, I think it's on us, you know, over the next 5 to 10 years to really understand what's at the heart of this gap and take it head on. because it's such a critical, there's such a critical need of building back that trust to move forward as a society.
Before we go to the next panelist, just picking up on that, because I think it's really a C3 theme. What could we, there's a number of leaders, medical, political, other folks that are involved on this, with this group. How do you think what would be the path for helping to rebuild it? Because part of this obviously is, in a way, our responsibility for not recognizing this potential for a lack of trust in many ways. Any thoughts about that?
You know, I would say it, curious what other people think, but it starts with a conversation. It starts with understanding of where that gap is, why there's a mistrust, and really showing some empathy and really listening, right? And really trying to identify what led to this and how we can address it as a society. There's a lot of, broken souls out there, and we've got to figure out how to take this on together. And it all begins with listening.
Thank you.
I like that, Eric. I think that there's two threads to this potential problem in my mind. One is the evolution of information in this pandemic. Like, it seems like we've been wrong multiple times. And your picture of us crowded around with no masks on would cause anyone to question, what do they know to tell me how to kind of handle myself? They were saying masks weren't necessary, and now masks are. And it seems contradictory, whereas it's actually just an evolution of knowledge and changing guidelines and changing instructions as we learn more. We need to do a better job explaining that rather than just kind of coming out with new things that seem capricious. The other kind of theme that has struck me has been fatigue. And I think it's both frustration around this seemingly change in contradictory recommendations, but also it's been a year. And I don't know that anybody back in last winter expected it to take this long. And there's no obvious light at the end of the tunnel. There are some suggestions that things will be better in 6 months than they are today. But it's not going to be over in a week. And people are tired. We've seen that even amongst our own staff. It's hard to kind of maintain vigilance and really be acting in the way that is as safe as possible. How do we then communicate that to the public that we're all in this together? I think it starts with saying exactly that, like, we are here with you and we are experiencing this with you, and then a humility that makes it clear that we are not some arrogant scientific community on high that has all the answers, but we're doing the best we can to explain what we know today and try to keep everybody safe as best we can, and that we're going to learn something new and it's going to change, and that's part of how science works. But it is a hard message to swallow, I think.
Yeah, I want to jump in here. And
to me as well.
Yes, go ahead, Mark.
I'm about to introduce a question to you. Sorry, just one quick thing.
I just want to pick up because I think it all ties in together. What Eric said and what Karl said, and I think it all goes back to communication. There's a tool that we use in palliative care, which is when something is really difficult, naming it. And so naming the fatigue as part of our communication strategy is very important, and that's what you were referring to, Karl. And when you asked initially what surprised us the most, I was thinking the communication and the frequent communication, because things were changing on a day-to-day basis. Information was coming in, and whether it was hospital policies, whether it was policies within the state, travel policies. And so the continuous communication was key to keeping us going. And I was very impressed within this institution, the level of communication and how we were always kept aware of what was happening and why it was happening and the decision making. And I think that was tremendous in helping.
And thank you, Hibah, because that's exactly what I was going to ask you. Was within your background in palliative care, how do you think about this, particularly as Karl, as you were saying, humility? The two things that come to my mind our humility and our relationship with everybody, and then uncertainty. How do we both project confidence, but also with humility and with the recognition of uncertainty? And I think that we as healthcare leaders and those that are engaged really have to wrestle with this if we're going to do better with our next challenge, which is certainly to come. So with my next question is related, which, knowing what we know now, what would you do differently? Any takers?
Well, I'll just build on the simple ones. Karl and Dr. Osman alluded to it. Get those masks on earlier, social distance earlier, wash your hands more. I mean, those are, look, I mean, it's challenging, right? And I think, the sort of Tuesday morning quarterback is always a good question. But the hard thing is, for the most part, we as humanity are typically just focused on the thing that's right in front of our face. It's hard to look ahead. It's hard to say, this is a potential thing that may happen. Let's actually go about and plan and prepare for these pieces. And we've got to think about what's most likely, allocate those resources to what's most likely and build on it. And that's sort of the bedrock of preparedness, is having an all hazards response. We're not going to have thought through every single possible variation, but as long as we have the construct to respond and recover and the principles down, then we can navigate that through the uncertainty. But I think, to your question, what could we do differently? Boy, I think back to, a big thing for us is Ebola, and we came out of that with a much more robust plan around infection control and training for our staff on donning and doffing equipment, et cetera. We could have maintained that with a modest budget to maintain the hardcore of that program, and that would have been much more scalable than sort of reinventing the wheel as we did. That's a simple low-level thing, but that's a very easy scalable thing. So, invest with some funding. I mean, there's some data that people have suggested for every $1 of preparedness that you spend, you save $100 in response and recovery. I don't know if that's mystical thinking, but it's certainly something to consider.
Other thoughts on that?
The other thing that kind of keeps me a little bit awake at night is our decision to really cut back on anything deemed elective. We went from 100 to 0. And I was one of the people in the room arguing we should go to 0. We should have gone to 0 yesterday, really worried about it. In retrospect, that's not our plan going forward. And I wonder whether it was a little too draconian as we realized that there were patients who had kind of more urgent issues, who we probably didn't serve as well as we could. And I don't think that's because we shut down as much as it's because they didn't necessarily feel safe accessing that care. But what is the right level of continuing your normal operations in a crisis, and how do you balance that? I struggle with it. And I think we could have been probably a little bit less draconian, but at the moment, I will, faced with the same decision today, knowing what I did then, I would make the same decision now. Knowing what I know now, I might approach it a little bit differently.
Dr. Osman, any comments?
Yeah, I think we approached this like a sprint. We went through it thinking this was going to be a month or a couple of months, and we weren't in the frame of mind that this is actually going to be a marathon, and a really long marathon. Now we know. So I think the decisions made at that point in time were very appropriate. The procedures, the elective procedures you were delaying, you thought you were delaying for a month or two, and that didn't turn out to be the case.
We have one specific question that came in asking your vision for potential expanding special COVID-19 mobile urgent care units. Probably Karl, you'd be the one.
Yeah, I mean, that really gets to that kind of centralized versus decentralized approach. We did have a number of RVs that we kind of drove around the neighborhoods and put in various locations to do COVID testing and social determinants of health screening and kind of food outreach. If COVID hits crisis levels again, I think that's something we would explore. But we're better served by having that kind of capability at all of our locations, which covers a much wider distribution, and maybe having one or two of these things that we could deploy to particularly hard-hit areas where we may not have a physical asset in the immediate neighborhood. So I feel like the distributed approach kind of obviates the need, hopefully, for the mobile units.
Well, thank you. And last question, Dr. Osman, can you I think we have about a minute left, to talk a little bit about the International Patient Center and how you think, how have we fared, and where have we done well, and where can we do better with our international patients?
I think given the huge restrictions with the travel restrictions, we did pretty well, and we have used this opportunity to improve systems, improve our triaging systems. We have new people on board who were trying to work on process efficiency, which in the past we didn't have the time or the bandwidth to do. So we have taken this opportunity to improve processes. And like I said, we have done a great job with reaching out to our colleagues in different countries and our networks, and that's actually going to help us moving forward. So overall, even though volumes were down, I think we did pretty well.
Terrific. Well, thank you all panelists, and very happy to turn it back over to Ransel Potter.
Well, thank you all panelists. That was a terrific session, and very, very honored and flattered to have had you all participate and support the C3.